And now I'm pleased to introduce Paula Griswold. She is the Executive Director for the Massachusetts Coalition for the Prevention of Medical Errors. Paula is the head of the coalition, which is a statewide public and private partnership of state, federal government officials, as well as professional associations representing hospitals, physicians, nurses, long-term care institutes, as well as professional liability organizations, researchers, consumers, and purchasers. Again, I am pleased to welcome Paula Griswold, and I will turn the session over to her at this point.
Thanks so much, Kim. Can you hear me?
I can. Thank you.
Oh, great. Well, I really appreciate the invitation to talk with the Mass Association of Healthcare Quality about this important work in this state on improving care transitions and end-of-life care through working across the care continuum. And to start, I actually wanted to provide some context for the presentation today. Our Massachusetts Coalition for the Prevention of Medical Errors had about 5 years ago identified improving care transitions as one of our top 3 priorities. Since then, we've been working with many organizations and many projects across the state trying to help to coordinate among them and support the work of the participants. In fact, I can see already from the registrants that a number of you have been involved in that, so we really appreciate those many partnerships involved in that work. What has happened is it's highlighted several improvement opportunities, not only specifically in the area of improving care transitions, but also in improving end-of-life care. So Kim had asked if I would do this presentation today and give the audience a sense of the objectives and components of 3 specific projects in Massachusetts. The MOLST project, and again, with apologies for those of you who've been deeply involved and may know these better than I. MOLST is Medical Orders for Life-Sustaining Treatment, the ability to turn patient preferences for their end-of-life care into an actual medical order. Second is the Interact project, which is a quality improvement program with a target audience of skilled nursing facilities, helping them improve care so that they could reduce transfers of their patients to the hospital, avoidable transfers of their patient to the hospital. And finally, Impact, a project to improve the electronic transfer of information to improve care coordination. And an exciting thing they've done is to really view that as longitudinal, ongoing care coordination, not just episodic. So I'm going to give some overview of each of those 3 projects, although I am not the expert in those projects. The experts have kindly agreed to share their slides and materials so that I can share them with you, and also, frankly, so that you can use them with other audiences. So these are intended to be resources for you. Then through these discussions, I'd like to have the chance of showing the advantages of working across the care continuum with a cross-continuum team in each of these projects and on all of these efforts. Say a little bit about some of the successes and barriers that teams have encountered. And then in conclusion, I'd really love to extend the invitation for you to give us some ongoing advice to help with this work. So that's the big picture. And I think that was essentially also the objectives for this call. No one knows the problem of care transitions probably better than those of you on this call, so I won't dwell on this slide. I just always find it helpful to be reminded and to remind others that every system is perfectly designed to get the results it gets, as we've learned from Paul Batalden and the Institute for Healthcare Improvement. So if we see problems with the results in the healthcare system of when care transitions occur, we need to go back and look at the design of the system and see what we need to change in the underlying design. But again, no one knows better than this group, so I won't dwell on that. And then the types of problems we've seen for the Mass Coalition, our concern was the risk of patient harm at transitions of care when there is poor communication and little accountability or ownership of the management of the transition itself, it also turns into some poor patient and family experiences of the transition. And then specific to our topic today, as we've discovered, often a failure to recognize and agree on the goals of treatment, and especially the patient preferences for end of life, and have those respected in every care setting the patient goes to. So that's our context. And again, from the names, it looks like many of you have been involved in this project, but one other piece of background, about 4 years ago, the coalition became involved in the state partnership working on the project named STAR, State Action on Avoidable Rehospitalizations, with the partners you see there at the top, as well as many others. I know Kathy Foss from MassPro is on the call, and I'm just realizing as I look at this list, we're not acknowledging all of the many other partners. One of the most valuable and most interesting things in the power that it demonstrated for improvement from that project, right from the beginning, hospitals were asked to form a cross-continuum team involving a physician office, a home health agency, a skilled nursing facility, or over time they were asked to involve as many as would be meaningful to help them improve care for the majority of their patients. Also to include patients and families in that work, although as we'll see in a minute, that wasn't necessarily as common. Another thing we were very excited about with that project, there were more than 50 teams that were formed in Massachusetts over the course of the STAR project. And those teams were asked, first of all, to perform a diagnostic review looking at 5 readmissions and help think about what were the contributors to those readmissions, and then work specifically on a set of changes in 4 key areas. Again, I won't go through these in any detail because many of you are already the experts in these, but there were a set of changes in the category of enhancing the assessment when the patient was admitted to the hospital, making sure to include family caregivers and community providers in that discussion and do a good job with medication reconciliation. There was a really thoughtful focus on how do you provide effective teaching and enhanced learning with a recommendation to include all of the learners. So if there was a family caregiver who was the patient's care plan partners, as one of the team called it, to make sure to include that individual, and then also to do teach back. So don't just provide the information one way, but check in with the patient, with the family caregiver, what was their understanding of that information. Improvements in the area of conducting real-time handoff communications in a patient and family-centered way, and then in ensuring post-hospital care follow-up, especially with a physician office visit within a narrower range of time than people had necessarily been doing in the past. So again, lots of efforts there that many of you have been involved in. I just wanted to show a couple pictures that were done based on a survey last spring of those the respondents among the 50 teams. So this display is showing you a set of those interventions, and the teams were asked to what extent they were working on them. Had they not yet tried the change? Were they implementing in a pilot unit all the way up to spreading it across the whole organization? So you could look at these slides more later, but in general it gives you that you can see many more teams were doing medication reconciliation and working on a written care plan. Not as many had included patients and families. Surprisingly, in a way, even not as many had included community caregivers at this point in time. Not as many were working on what was called a warm handover, which we'll talk about more later, which is a real person-to-person communication for the transfer. And just the other quick picture I wanted to show you in terms of working across the continuum, the teams were also asked to whether or not they were working with all of their community partners on the process changes that they were addressing to improve care transitions. And the wonderful thing we saw from the survey at this point is that the blue line is much longer, that overwhelmingly teams were really working across the continuum with their community partners. So that was STAR. And as we worked on STAR, we started to reach out and identify and try to coordinate with these other activities in Massachusetts that were related to improving care transitions, improving end-of-life care. So the first one then on our list is medical orders for life-sustaining treatment. Now I'm not sure how well this is going to work, but could we try just to, I think that our tech administrator here could open up the audio. I was interested in people just speaking up if you're already pretty familiar with MOLST. The conference has been unmuted. People already familiar with MOLST, just say yes, and it'll, by the number of voices, I'll be able to tell how much detail to comment.
Yes.
Yes.
Yes. Yes.
Okay. That sounds like there's still some people not saying yes, so I'll appreciate the patience of those of you who are experts. And again, I wanted to give you some materials that might serve as a slide set for you. And my appreciation to Greg Bird, who was the Chief Nursing Officer at Northeast Health Systems, and then recently worked as VP for care management for the Leahy Accountable Care Organization. Many of these slides were from Greg, and he kindly agreed to share them with me and with you. So people may know MOLST. The conference has been muted. The conference has been unmuted. Oops. Can we go back to muting? Are we going back to muting? With Commonwealth Medicine at UMass Medical School, who, if those of you might have been involved in some of the educational materials, Christine McCluskey there and her staff just been doing a wonderful job of providing educational tools and settings. But if you haven't heard about MOLST, to make sure you are aware of it, at least from today's call, again, a medical order for life-sustaining treatment. It's a written instruction in the form of a medical order from a clinician. So physician, I'm not sure why that says MS, nurse practitioner, PA, 2 other health professionals. So it serves as a medical order. And it's specific. Those of you who've seen this form in detail, it asks in more detail than is certainly available in some of the other types of end-of-life preference forms. It asks about CPR, ventilation, transfer to the hospital, intubation, dialysis, artificial nutrition, artificial hydration, and each of them specifically to have the chance for the patient to have a discussion with a medical professional and understand those choices and express their own preferences explicitly, but in this form that turns into a medical order. So then it's intended to be a portable document that is honored by all healthcare professionals where that patient receives care and valid across healthcare settings. And it's up in that top corner. The MOLST project has even a specific color that they've recommended as people print and use a MOLST form so that it could be standardized, easily visible, and recognizable by everyone. Again, the notion of MOLST is to have the patient, it's not intended for everyone at all times in life. MOLST is really specifically for those with an advanced progressive illness or frailty. But to have those patients both identify and determine their preferences, but specify them and document them in a way that they could be followed in all of their care settings. The other thing that has started to be much more important as people are working on implementation, the original goal was for statewide MOLST use in 2014. So you don't have to read all the detail here, but this was just the background saying that there there was Massachusetts legislation in 2008 that was the beginning of this discussion. There was an expert panel created on end of life that reported out then in October 2010. And the expert panel's report made the recommendation that there should be full statewide implementation no later than January 1st, 2014. And my sense is that there is a great variation across the state of whether communities have completely adopted that deadline as a goal for themselves and worked on the internal implementation. But we haven't, I have to admit, we have not systematically evaluated that. Again, you don't have to read the details here, but for you to have this, the original direction was that MOLST should be meaningful so that every appropriate patient is afforded the opportunity to complete a form, that all emergency medical technicians would have had the training so they are prepared to honor the form, that all hospitals and healthcare plans would have the policies and procedures in place to honor the form and utilize the form, and every clinician would have had an opportunity to improve their communication skills with patients at end of life so they could help them complete the form. So again, my understanding is people are all across the spectrum in terms of the level of readiness for this for certainly a January 2014 date. But that was not, at this point, that was not a requirement. That was a recommendation. So it was an encouragement, but there is not a penalty. By the way, I'm hearing a little bit of background noise. I don't know if there's any way to do anything about it. I personally am fine, but
we can mute everyone, and then you have to unmute yourself. That's what happened a couple of minutes ago. I was trying to do that, but
well, you know what? We won't do the audio polling. I'll just assume that some people know about the things that I'm talking about and try not to bore them to death.
Okay. Then once I hit mute all, you have to do a *7 to unmute yourself.
Okay. And at the point that we get to Q, so I'm sorry, you'll need me to do *7. Is that what you're saying?
Yeah.
Yep, I'll do that.
You ready? Okay, I'm gonna mute everybody, and then you're gonna unmute yourself with *7.
Great.
On your phone.
The conference has been muted.
Hi there. Hoping that I'm back. If you can put in the chat box if I'm not audible. So again, I don't need to read these to you in detail, but these next set of slides were from, again, my appreciation to Greg Bird for providing people some statistics that if you're reaching out to others to say why this is an important form to use for patients, so just to highlight a few of the statistics here, from the expert panel report, there was the finding that 67% of Massachusetts residents have made the decision that they want to die at home, but if you look at results, only 24% do so. Many other people dying in hospitals or other institutions. From some other sources, 50% of terminally ill patients had an advance directive, but many of their physicians did not know it. 80% of patients said they'd like to be able to talk to their doctor about end-of-life care, but a very small number, only 7%, report having done so already. So again, some statistics to provide you a resource here if you're talking to others about the importance of MOLST. That many people say it's important to have these wishes in writing, but few of them have already done that. 80% say their families know exactly or have a good idea what their preferences would be, but only 50% have talked to their families about those preferences. And again, I won't go through the rest of these slides and read them to you, but to help you make the case. This bar graph is from the expert panel's report showing variation among Massachusetts hospitals. There is substantial variation. The left-hand set of bars is each of them represents a teaching hospital. The right-hand set of bars in the community hospitals. This is what % of patients during their terminal hospitalization had an admission to the ICU. So you can see tremendous variation from less than 20% to over 70%. And some of that the implication is because we do not know the patient's preferences and are not following the patient's preferences. Again, more statistics that might help you if you're working on engaging those in your community and using the MOLST form. There are many more deaths occurring in hospitals from patients who had been in skilled nursing facilities without the MOLST than if they had a MOLST form. Similarly, if the number of patients, this is from the Wisconsin program that used MOLST really comprehensively community-wide, they were able to change the number who had documented preferences that they did not want, patients who did not want to return to the hospital, and increased that amount 6-fold. So again, I think I've already emphasized that the notion of MOLST is to help follow the patient's preferences. It is not to reduce care for patients when they are terminally ill. In fact, the MOLST program will emphasize that this is as much the opportunity for a patient to say that they do choose some of these interventions as that they don't choose these interventions. The whole point is to have the patient understand the choices, express their preferences explicitly, and then to have them respected by the healthcare system. So many of you may be familiar with this already. That there's a wonderful website for MOLST that has some self-teaching materials on it. It has materials you can download. It has audio presentations that people can watch on the site. And again, with Christine McCluskey's name here, who's been the Director for Community Outreach and MOLST Expansion statewide at Commonwealth Medicine. And I was just in touch with Christine, and she reminded me to please alert people to the fact that on the MOLST site, if you go from the home page to news and then click again on more news, you'll see the upcoming learning opportunities for different kinds of settings. So there are a series of regional meetings that are coming up in November and December. There's another emergency medical technician training. There are drop-in sort of office hours calls if you've been working on it and you just want to get some questions answered on the second Friday of every month. So all of these opportunities are listed on that MOLST website. So that's MOLST, a really, really wonderful program that, as I say, as part of our work in looking across the state and identifying how can we improve care transitions, and within that do a better job of respecting patient preferences at end of life. MOLST is a very powerful tool and is not just the form. It also the trainings will connect you to those other materials and activities to help clinicians have the communication skills and for some of the strategies about how you might implement community-wide across the care continuum. The next project that I wanted to make sure you were aware of, again with apologies for those of you who yourselves are experts in the project, is Interact, which is a quality improvement program whose target audience is skilled nursing facilities that has a really wonderful set of very concrete tools and implementation materials that together make up a practical approach to safely reducing rehospitalizations from the skilled nursing facility. And in this case, I want to thank, all credit goes to Lori Herndon Many of you know Lori, the Director of Clinical Quality at Mass Senior Care Foundation, and also a key developer and part of the faculty for the Interact project nationally. And in fact, again, apologies, these are slides that Lori had used at a September program, so you may have already seen the slides, but you can now have the slides set yourselves. So Interact, which was the name was derived from the Interventions to Reduce Acute Care Transfers, ACT Act. Again, a quality improvement program focused on improving management of the acute change of condition for residents in skilled nursing facilities. So it provides educational and clinical tools and strategies to help the frontline staff in those facilities recognize those changes early, assess the patient's need, document them, and provide better information to communicate to the hospital if there is the necessity for a transfer to the hospital, so that it could be a more rapid transfer when a transfer is required. Again, background information if you are talking to people about Interact, but again, probably no one knows better than this group the issues of rehospitalizations from skilled nursing facilities. Here's some of those statistics. That 1 in 4 Medicare patients are readmitted to the hospital after a hospital discharge within 30 days. 2/3 of those in a study were considered potentially avoidable if there were this better evaluation, early recognition, and assessment and care management in the skilled nursing facility. Again, that there are starting now to be more financial incentives to reduce those potentially avoidable hospital transfers. So lots of reasons to use Interact. And then I realized I didn't put the results into this slide and could provide them afterwards, but Lori had sent on to me that there, in the pilot done for the Commonwealth Fund, when they had 25 skilled nursing facilities participating in Interact, they saw a 17% reduction across those facilities in the mean hospitalization rate per 1,000 resident days, which actually in a way could be even more impressive when they stratified that group by the facilities that were really very engaged in using Interact and those that weren't. So the 17 facilities that were very engaged in Interact actually saw a 24% reduction in the hospitalization rate per 1,000 resident days. So already demonstrated results from this work. You couldn't possibly read all those words on this slide, but I just want to acknowledge that there's Interact is a trademarked program. The goal is not at all to limit the use of the tools by clinical sites that are trying to improve care. It's really just to prevent the inappropriate commercialization of those tools. So all of you who are using them to improve care for your patients, not a problem at all. Again, another version of the purpose of the Interact. It's to improve care for the patients in skilled nursing facilities and thereby reduce the frequency of avoidable transfers to hospitals, which as a result will minimize the risks associated with hospitalization. And it does that by improving early identification and assessment of patients. A continual emphasis that the target is preventing avoidable transfers, not preventing all transfers. And if the patient does need a transfer, making that more rapid and with a better communication of information. So those of you, if you have not been to the Interact website, there are a substantial number of tools right now for skilled nursing facilities, and the promise of tools coming soon for other care providers in the continuum. So right now those tools are to help skilled nursing facilities work with other care providers. It looks as if there is a promise to also develop tools directly for the other settings. Again, you may be familiar with the type of tools here. This is the website at the bottom there, and there's tools in 4 categories that you can see there. I just, on the next couple of slides, had shown you some more of the specifics. Among the communication tools, there are a set of tools that the skilled nursing facility could use in planning care improvements with the hospital, and then specifically for transferring individual patients, depending on the form you're looking at there. There are also a set of tools related to advanced care planning. I'm not going to talk about those. I'm actually not familiar with the detail there, but it had made me realize that in terms of the MOLST activity, that there are lots of planning tools, and it might be something that we want to think about statewide of how to help people understand the integration of the various forms and proposed approaches. So a particularly wonderful thing about Interact is the practical, simple, straightforward guidance for implementation, for thinking about starting where you currently are in your organization and successfully making these changes to improve care. So there is a full implementation guide on the website to help you develop a work plan. There were just a few things that I wanted to highlight in terms of how Interact can work improving care transitions across the care continuum. Again, with my appreciation to Lori Herndon for her laying this out. So Lori had emphasized that there are many forces now pushing hospitals to work with skilled facilities and to use Interact. In fact, in some cases, it's turned into a requirement to use the Interact tools. There is language actually that was developed by the Massachusetts Accountable Care Organizations that were sort of idealized standards for care that's directed both organizations to use Interact in transferring and communicating about patients. The hospital engagement network activity now has often pushed the use of Interact, and there have been payer incentives as well in Massachusetts for the skilled nursing facilities to use this program and use these tools. Lori had emphasized that as people are starting down the road using Interact, to make sure to recognize that there are kind of 2 levels as you develop your facility team to implement the program. There's a role for your facility leaders in improving relationships with the other organizations with whom you are coordinating care for your patients, especially the acute care hospitals. There's also the activities for the frontline staff, how they understand and improve care, as well as potentially their planning processes across the continuum with those other facilities. So again, I'm not going to go through every one of these lines, just to highlight for you some of the forms and some of the tools and the key strategies in how you use them. In the guide for facility leaders, Lori had recommended to really make sure as a skilled nursing facility approaches hospitals about working together to improve care transitions, that the SNF has already done its homework to know their own data about what their readmission rates are, and be sure that their things are well managed, as well as being able to share the story of how the facility is able to provide good care within the facility and be effective in these care transitions. So both the qualitative and the quantitative part of that approach of the SNF facility leader being prepared to talk to hospital facility leaders. I kept this in because I thought it was I don't know how prevalent this still is, but this was from Lori's presentation, something she'd heard recently from a skilled nursing facility saying to Mass Senior Care, are you guys doing anything to educate hospitals? Because we've been told we are required now to use Interact, but the hospital or the ACO leader didn't know what Interact is. So part of the reason for commenting on this today to make sure everybody knows about Interact. The second tool that was listed there under the communication tools within Interact, and Lori notes there's been a lot of interest in this form, is the opportunity to explicitly communicate from the skilled nursing facility to the hospital, especially the emergency department and care managers, what the capabilities are of that skilled nursing facility. So you can't read it on this picture of the form, but it's specifics such as what the physician or nurse practitioner or PA coverage is, what the facility is capable of in terms of diagnostic testing and consultations, specific interventions, their ability to do IV fluids, IV antibiotics, IV meds, insert PICC lines, manage PICC lines, and as Lori emphasized here, it's not about checking things off on a form and turning a form over to the clinicians in the emergency department, but actually it may even be at least having a conversation. It may even be having a visit, so that there is a good understanding of the capabilities of the facility, and the emergency department clinicians then might have the comfort level saying, well, we know that we can assess the patient after they're sent from the skilled nursing facility, come up with a treatment plan, but we know that this SNF is going to be capable of providing the services that are part of this treatment plan. We know that this patient can be cared for if we send them back. So we don't need to admit the patient. We have the relationship, we have the knowledge of the SNF that they can do these things that are in the care plan. And again, with all of these things, it's usually not about the form. The forms helps you be systematic and thoughtful and have a detailed discussion, but it's often about those discussions and those relationships. Another tool I think might have been added to Interact, if I understood from the presentation, as a result of some of the great work that was done in Massachusetts. And there was an envelope with the document checklist that helped ensure that all of the forms and information that should be sent to the hospital as the patient is transferred are actually included, as well as the communication between the two organizations so that this is actually opened and the information is used. So when the hospital receives it, they know what it is and they know how valuable that's going to be to them. And it just doesn't end up on the right-hand side either returning to the SNF without ever having been opened or thrown in the trash. So again, it's about the discussions to agree on what is the standard process so everyone recognizes when this form comes over, oh great, this is the treasure trove, this is what I needed to know about the patient who's arriving. There had been an emphasis that the importance of the role of the frontline staff, that there's a number of tools that will help them with the care within the skilled nursing facility. I am not going to go through the specifics here. Again, it's never just about the form. It's about, in a standardized way, helping people provide good critical thinking, good clinical assessment, and good clinical care, and then communicate that across settings when the patient is transferred, frankly, in either direction. So I'm just going to keep going through Interact here. Again, not about the forms. It's always about the relationships And one specific issue that was addressed in terms of improving the relationships is how to do this warm handover that many sites have found is a really valuable way of improving care across the continuum, either when the SNF patient is transferred to the hospital or the hospital patient is transferred back, that there be a nurse-to-nurse discussion about the patient. And so this is kind of the checklist of understanding how do you start to develop a standardized process. How do you identify what's challenging and make improvements in that process so that the warm handover isn't too difficult for everybody to do and everybody can do it consistently. Again, just a recognition that there are tools in Interact that may help with this warm handover, and I'm not going to go through those in detail. But Lori had summarized how valuable Interact was. There's starting to be financial incentives that encourage the use of it, but what it really does is improve care for the patient, the resident within the SNF, and improve the transfers and communication in both directions. And this had been her parting encouragement that everybody use this opportunity to improve care. So the final project to make sure you know about is called MAHQ, and I apologize, all these acronyms, but hopefully you have the resources here to go back and remind yourself. MAHQ stands for Improving Massachusetts Post-Acute Care Transfers, but the focus is really about building into electronic communications the key information that's necessary to improve care across the continuum. And as I mentioned, one of the wonderful things that happened is they decided as they were doing this work, originally they started to look at the transition as sort of episodic, as a one-time event. And then there was the recognition, you know, my gosh, what we really recognize is often missing as we transfer a patient is a sense of the larger picture. What are the treatment goals? What is the larger care plan that represents the needs of this patient? Not just they showed up in the emergency department last night. So all credit to the MAHQ project and to Larry Garber, who's Chief Information Officer at Reliant Medical Group, Terry O'Malley, who's the other project lead with him, and the whole team working on MAHQ. Some very exciting things done here to acknowledge the information that should be transferred and to support that with electronic communication so that it's not so challenging every time a patient needs to be transferred that there's such a huge workload to collect and send the information. So I'm going to speed through some of these. Again, no one needs to tell you the problems of care coordination that that everybody is trying to address, but here are some more statistics in case you are making presentations and need those facts at your fingertips. And the particular focus in the case of the MAHQ project was the need to improve the information flow and exchange as part of improving care transitions. Don't worry, you're not supposed to get anything from this, but oh my gosh, care is complicated. The point was the MAHQ project was recognizing that there are a huge array of different types of transitions from one setting to another. I think this was from the National Stroke Post-Acute Care Study. But what they recognized were their goals is they wanted to communicate the right information to the right people in the right location in the right format, but that could be different for different types of care transitions and could be hard to have one standard transfer form that would work for all settings. So they said they were going to need to support that by having data standards appropriate to these care transitions and then tools that make it feasible. So that's the goal of that project. They were hugely helped by a federal grant of $1.7 million in February of 2011. And these were then the four parts of the grant. First was to figure out what are the data elements that are appropriate for transitions and try to turn that into a national standard. Second was to develop software tools that would make it easier to collect and send those data elements. Third was to pilot it in the Worcester area in a way that they could test and improve both the elements and the approach. And then finally to measure the outcomes. These are the metrics that they're using, not to dwell on those. And I'm just going to keep moving quickly through each of those 4 parts of the work so you have a big picture sense of it. First was to develop what are the data elements that should be a national standard that would be communicated. And they early on said, well, traditionally this has been whatever the sending organization puts into the form that they pass on. And shouldn't the impact project be much more thoughtful about what the receiving organization says they need to care for the patient? So in a way it sounds incredibly simple, but was hugely valuable for this project that they were so attentive to the needs of the receiving care provider. Again, you're not supposed to be able to read this, but it's just pointing out how many different permutations of types of transition there would be if you're looking at, there's 14 types of care organizations down the left-hand column that might be the sender of the patient, and those same 14 types of organizations that might be the receiver of the patient. It's very challenging to think about what's needed for care transitions. So in this impact project, they surveyed receivers to identify what kind of information they needed. You don't have to worry about the detail here. The message is Impact did this in a very comprehensive and thoughtful way in really listening to receivers. And what they identified from the receivers was which data element would be required for each transition. And this is the time at which they recognized that there was no one form that would fit all needs. So from the impact project, they focused on 5 different transitions that seemed to capture a common set of needs within each of those transitions, but different amongst them. So there was what's the report from testing, what's needed in the referral to testing, what needs to be shared about a care encounter, what needs to be communicated when there's a request for a consultation, and then if there is a transfer of care from one facility to another or to a home health setting, what information needs to be communicated in that type of transition. So those were the 5. Again, you don't have to worry about the detail. That's just showing that among those many permutations, they picked those 5 to address. And those were the data sets that they worked on. The other particularly exciting thing about the impact project, they said what matters is the care plan, not just the episodic care transition. So you don't have to worry at all what this slide says. The point is the impact project was very thoughtful about could they support what was needed for longitudinal care coordination, for ongoing management of care by the receiving organization knowing a care plan and not just something about where the patient was yesterday and how they were yesterday. So a particularly exciting part of this impact project. The next thing that they did was to test the data sets, the data elements. They started in 2011 in the Worcester area, and that was testing what's the information that's being communicated. And again, I'm not going to go through detail here, You can have these. You can look at these later if you'd like to. They said these are our criteria of what matters. It has to be valuable. It has to be a feasible workflow. And it has to be trusted by all of the care providers. It has to be meaningful information. So that was additional detail about those principles. They did that again in a very inclusive and comprehensive way across the care continuum, talking about those data sets. Surveyed the users to find out what was feasible to send. And they found out that actually for the most part, the senders were able to send the information that was requested. The receivers got most of the information that they needed. And there will be further testing of the current version of the data set that's going to start this November, this time with an electronic exchange of the information. So that's the last piece to alert you to in impact. And let me keep moving along because I see the time's moving on. The impact project has been working with the National Meaningful Use Standards setting bodies so that the lessons that they've learned and the data elements that they've identified as critical may actually turn into the meaningful use standards. So it sounds very exciting, very productive if that gets incorporated based on this thoughtful approach. And then I'm not going to go in any detail through these slides with the cute and thoughtful names they gave them, but the notion is just that they are building the electronic communication capability across sites so that it works if an organization has an electronic health record. If they have an electronic health record, they'll use this thing that Impact is developing called LAND. And if the organization doesn't have an electronic health record, there'll be a web-based communication capability cutely called C. So it's Land and C, like Paul Revere. That will, the other exciting thing about that is not only can an organization that doesn't have an electronic health record receive this information, but they can easily then modify it on this web-based confidential browser and send it on to the next site of care. So this is what they'll be piloting starting November. The capability that have they created these software tools that would enable the easier collection and transfer of this information electronically, whether an organization has an electronic health record or not. So a very exciting part of the Impact project. I'm just going to pause on this for a moment to say the project has also been very, very thoughtful about usability and what's feasible for people to use, and they've tried to make it as possible to copy meaningful data from an existing document, not just mindless copying, that the format should be very intuitive to use, that they allow you to include free text narrative if that's important for the patient's care. And if you start typing, they bring up there's logic that brings up what you may be typing to make it easier to enter the data. So really a very thoughtful approach to usability. I'm not going to go through the specifics on the software, but just the Impact project has been tremendously exciting in its thoughtfulness of identifying what information is needed, feeding that into the national standard process, and then hopefully building software tools that make that information easy to collect and transmit whether an organization has an electronic health record or not. So I'm sorry, I realize I'm running really late here, but just to go really quickly to summing up from the perspective of the coalition. As I mentioned, we have a steering committee that we've been working with, and we are deeply grateful to all of our partners. And there's a number of other projects that we have been following to say what all is going on in care transitions, how can we keep that coordinated, where are there gaps, how can we support shared learning. And then one thing that has come up is really probably more need to build a strategy statewide to help people improve end-of-life care. So how can we improve end-of-life care within this effort to improve care transitions? And then how can we assess, are we having the impact that we'd like to see? I probably don't need to tell you all the challenges. You're probably the experts in the challenges within care transitions. We've seen how frustrating it is that everyone has too little time, constrained resources, too many priorities. In a way, sometimes all of this work has thrown too many cooks into making this broth, as the patient might end up getting care management calls from lots of different providers while people are working to improve care, while are we still building workarounds, or are we solving the underlying problems? And medication reconciliation continues to be a huge challenge, so there's others. What we've seen in the ongoing challenges with end-of-life care and the palliative care is, again, that picture that has said that there really could be more that we could do to help support this statewide. With intensivists saying, I've just met this patient, I've just met this family, and no one has ever told them that this is a terminal illness. But the PCP saying, I have no time and I may not even have the skills to have this complex and serious discussion, the most important discussion this patient may ever have in their lives. The SNFs may be dealing with disagreements among family members, and there continue to be payment issues, so many challenges with end-of-life care. So the bottom line for the coalition is we're going to be continuing to work on this with many of your organizations. We would love to have your input of what else should we include, what other projects should we coordinate with. Do you see other problems or issues of unmet needs that we should be addressing? Do you have suggestions of opportunities that we could incorporate? We'd really love to follow up with you. So I apologize because I realize I've basically run us out of time.